It's a real privilege to have Dr. Julia Cohen-Levy, who we're very fortunate has relocated to North America from Paris, France. So I had the privilege of doing a sabbatical in Paris over the last year, and I was invited to be a lecturer at Paris Diderot University in the first dental sleep program there in a university setting. And Julia's work figured prominently as foundational in establishing sleep medicine in France, and we're very excited that she's now at Université de Montréal here in Canada to continue her great work and also shine a spotlight on myofunctional disorders and myofunctional therapy. Thank you very much.
Thank you, Mark. Thank you, Sharon. Can you hear me, all of you? Maybe not. Maybe here you can hear me then? Okay. Thank you. Okay, I need to push it. Too small.
Here, I can fix it.
Yeah. Thank you. So the topic today will be persistent obstructive sleep apnea in pediatrics. So as Mark said, I'm an orthodontist. I graduated in France and then I moved to Canada to do a postdoc research study in the lab of Dr. Nelly Nguyen. And this is the hot topic today. So yes, you all know what sleep disorder breathing is. This is the repeated episode of partial or complete upper airway obstruction during sleep. And it mostly happens here in the collapsible segment of the pharynx in relation to the inspiratory force that creates the negative pressure. Because the nasal passage and the trachea here can resist this depression. So the factors that will favor this collapses in the pharynx segment would be biomechanical, so it could be the difference between the skeletal frame and the soft tissue content within the airway. So it will lead to increased airway resistance. And you will have also compensatory factors which will be active contraction. So you don't have only a biomechanical model, but also reflexes, muscle tone reaction. And what you need to keep in mind with the child, this is that everything is really narrow and is growing. So if you have, for example, allergy in the child, this with the proportion of the airway will reduce dramatically the lumen for passage of air. And also the ventilatory movement will be quite difficult, quite different, and you will have less apneas, more hypopneas sometimes. So one thing you need to know is where the obstacle is. Where is it and how many levels it can be on. Starting from the nasal passage and then from the adenoids at the posterior aspect of the nose, behind the velum, behind the tongue, behind the epiglottis. And it can be in several aspects. Then what you should know also is the pattern of closing of the airway. They can be partial, they can be complete, then can be in the transverse aspect, for example, in here with the palatal tonsil, or can be concentric. And of course, you need to know the severity of the issue. Is it snoring, chronic snoring, or is it going together with abnormalities of gas exchanges until obstructive sleep apnea that itself can be mild to severe. So all these different aspects you need to know when facing a particular patient. And well, this has been discussed before, but please, I would like to go back on this because this for me is the way to explain best what's happening in the child. And there is the fourth dimension that is really of major importance for me. And as an orthodontist, so this is the Scaman's curve modified by William Prophet, the orthodontist who passed away. And the crossing of these curves, even if the lymphoid curve is a little different from what we heard from our Japanese professor earlier today, you still have the explanation of both the etiopathogenicity of sleep apnea and also the effects you will have, both in the growth, both in the neurobehavioral aspect. So we know that the clinical peak of sleep disordered breathing is between the age of 3 and 5. This is where you have the most important surgeries for ANT especially. And the lymphoid growth maximum is, Scammon says, 10 years old, but he was taking into account in his studies thymus growth also. So when you just take into consideration the adenoids and tonsil, we are most closer to 8 years of age for the maximal peak velocity. So the trend is correct, which is you have a dramatic increase of the lymphoid content and then will slowly decrease to become normally reduced after 12 years of age. And when during this same time you have the crossing of the skeletal frame growth curve, and I need you to pay attention to these two curves that are slightly different. This is the maxillar growth curve and the mandibular growth curve. The maxillar growth curve follows the neural growth. Maxilla is pretty close to the brain, right? And the neural growth curve is dramatically important in the first years, and then knows a plateau, and it's over very early. At 7 years, the maximum volume of the brain is okay. This is why we use the anterior cranial base as a reference in ortho, because we know it's not going to change much. So the maxillary curve follows the neural, and the mandibular has got a different velocity, which means that this is normal for a child to have the mandible slightly retruded, not exaggeratingly retruded, but a convex profile is okay. And then this is normal, and they will catch up. So what is also very important here, so the mandibular curves mostly follows the general growth curve, which is statural growth increased dramatically with puberty and genital increase of size. And the other thing is this curve, the neural curve. We know that sleep disordered breathing is happening here. So the brain needs a lot of oxygen and nutriments, and so do you really want to have a child not cured during this special time frame? So for me, these curves crossing are very of main importance. Yeah, so you have risk factors we discussed a little bit before during the entire session, which is, of course, soft tissue hypertrophy, but also craniofacial abnormalities, abnormalities in the growth process. When you have syndromic cases, most of the time they have very complex and early onset sleep apnea, which means that they will be taken care of as soon as they were born to life, and maybe CPAP candidates or tracheostomy even candidates. So they are very severe cases. Let's not talk about these ones. I will talk about non-syndromic, mild malocclusion that and craniofacial abnormalities that could take part in the maxilla. And this is very important because the maxilla and the nasal passageway, they are the same. The maxilla is the skeletal frame of the nasal fossae. So if you have a reduced maxilla, then you have a reduced nasal passage, then you have an increased nasal resistance. And furthermore, the tongue has no place to be. So the tongue is in the lowered position. And if the tongue is in the lowest position, the tongue cannot counteract the forces of the cheek during function, during swallowing, during speech. So you have a vicious circle. So this has been described very efficiently by Christian Guilleminault, and he really believes in that. And yes, we all orthodontists are aware of this, so we pay extra attention to maxillary narrowing and nasal obstruction. Then you have another thing, which could be mandible retrusion, mandible hyperdivergence, which is a slight change in the shape of the mandible that would rotate backwards. And so together with the tongue base also will go backwards, and so reduce the airway. So all these craniofacial abnormalities are known and well-described risk factors for sleep apnea. I would say before the age of 8 in the publication, and this is really important. I know you like it. I know you like it, but I'm an orthodontist. I'm not a pediatric dentist. So what's going to come next, you will be even more happy, and I will fall into despair. So yes, obesity also maybe could be linked to soft tissue hypertrophy somehow because of the fat deposition within the tongue base or the lateral fat pads. But it's of reduced importance before puberty, but can be a problem for really obese children. Neuromuscular conditions, but also myofunctional abnormalities also could take part of this risk factors. And you have all the others that were well documented in the literature, and African ancestor history also, maybe because of soft tissue differences. So what could we do? We can increase the diameter of the pharynx and nasal fossae. Okay, so this is a biomechanical thing. So we go to the ENT, we do medical treatment or surgical treatment to get rid of everything that's inside the tube. Or we expand the frame to increase the tension and also to increase the volume of the maxilla with rapid palatal expansion, or increasing the mandible potential growth in a forward position. So class 2 correction, basically. Or we can reduce the compliance of the collapsible segment. This is what myofunctional therapy does. Yeah. I'm good. So how to treat? Well, today we need to rely on RCTs. We need to rely on evidence. So this is the pyramid of evidence. And for surgery, especially in children, you have to be very sure of what you are doing. And for ANT surgery, there can be a bleeding risk. So you have to document very carefully the OSA severity. But the first line treatment could be adenotonsillectomy or careful watching, as our colleague described previously, or medical local treatment to reduce inflammation. So can we wait? Yes, you can wait in these studies. If you wait, it will get better eventually. A lot of remission in the long term, but do you want to wait? Maybe not, because which way are you gonna go? You don't know if you will switch from primary snoring to remission or become OSA. From light OSA to moderate OSA, where are you? You might have some risk factors to guide you, but you cannot be sure. So the second line treatment will be, the rest, what we said. So now, I needed to tell you all this because we wanted to screen patients after ANT to check for persistent signs and symptoms and to check who they were. Do they have craniofacial problems? Do you have myofunctional problems? Are they obese? And then we wanted also to perform an objective sleep study. So this is what I did in my postdoc research. I took the 5,000 files, of the ANT database. I manually checked every file to be sure they had signs of sleep disorder breathing. We didn't have no PSG for all children because most of the time this is a clinical assessment. The child has witnessed sleep apnea, so okay, you go to surgery, you don't wait for the PhD, there is 1 year waiting list. So yes, this is the ENT, so I had to read carefully the handwritings of the surgeons. And then we sent invitation letters. I called them once, twice, 3 times to be sure they would answer. A very short questionnaire or postal questionnaire to assess using a Karen Spritz validated questionnaire, validated both in English and French. So there is a scoring and you have to make calculation. And then you have a score. And if the score is higher of 2.72, then you have a higher risk of persisting OSA, of OSA. This was the first line screening tool. So this is what I did. So 4,000 invitations, and 30% of them answered. And what happened is that it seemed to be very efficient. We had 66% reduction of symptoms. We suspected some persistent sleep disorder breathing in 25% of kids. And some of them had spontaneous remission from the time I called them and the time they answered the questionnaire. But this is part of the natural history. This can happen, especially after surgery. So it was 1 year after surgery, not in the following 6 months when we knew whether it can be edema and so on. So this is the typical, this is all the questionnaires I received. So you see patients were about 10 years old. They had been operated quite early at 4.2 years of age. Sorry, and it was representative of the entire cohort. And we investigated them almost 6 years after surgery, but with a very wide range. And this is interesting because this is the people who entered, and this is with their age, and sex, and here is their answers. So what you can see, yes, it was a lot of answers, but there is a difference between male and female, and there are 2 peaks in the recurrence of symptoms. So what is it? 2 peaks. First, we showed that the study sample was mainly male. Male had higher symptoms, and they also had been operated younger than girls. People also from African ancestry had been operated 6 months earlier than the others. And this first peak, that's okay. It's at about 8 years of age. Does it surprise you? No. This is what we said before. And this was also proven in this RMI study. This is a normal pattern of growth, maybe in people from European descent, maybe not in Japan, but this is the curve it has in RMI. It is slightly different, so you don't have this aspect for people with sleep disordered breathing. It seems to remain high. So this could be one explanation. So what could be the second peak? The second peak could be, see the age, 15, 16, could be the recurrence of the syndrome that was described by Christian Guilleminault. And in his study, he found that it was mainly boys. This is what we found also. And he said that there were abnormal clinical orofacial and myofunctional examination on them, and changes in PAS, the posterior airway space, that was reduced, as shown in here. And yes, this could be true because you know that the tongue has got 2, it comes from 3 pharyngeal arches, but has got 2 functional aspects. And in this study, designed to assess the development of the tongue regions, it appears that the anterior region stops to grow at age 8, but the posterior aspect continues to grow until at 15, 16. So it could account for this. So we wanted to examine them. So we did. I'm going to be very quickly because we took the Dr. Villa sleep clinical record. So we used the phenotype, and then oral breathing, and a sniffing test, a horizontal breathing test, and glaser mirror, taking into account the cycle, of course. We assessed for nasal deviation, tonsil for the ones who only had adenoid removal, and we did the scoring accordingly, as she said. And here are the results. And we did also a sleep study. So these are 100 patients completed the clinical examination. Only a few of them accepted to go to the sleep study. And this is what we found. We found that there were overrepresentation of nasal abnormalities. So there was really cartilage hypotonia in 18 out of 100 of our patients. And in twins, this is twin A and twin B, it was pretty much the same. Also, we found moderate tongue frenulum reduction in about 40% of our children. And they failed tongue elevation tests. I was asking them, put your tongue up, and they just wouldn't understand what I was asking them. And so, what is it with the sleep study? And guess what? The phenotype described by Dr. Villa was really associated with pathological sleep parameters, so the narrow palate, but just a tendency. The malocclusion? No. So I was in shock. But then when I did a subgroup analysis before the age of 8, then yes, it would be related to abnormal events, malocclusions, but not after for the entire group. And guess what? Nasal obstruction, oral breathing, motor immaturity were also correlated to abnormal sleep events. So they were more functional than anatomical issues. And we also found, this is the last thing, so yeah, the inability to elevate tongue was associated with abnormal respiratory events, and the Guilleminault nasal reflex also. Anyone know this test? Yes, you do. Of course, you do. So this is the nasal Guilleminault nasal reflex is the dilatory naris reflex. So what is if you pinch the wings of the nose? After a few seconds, you have a dilatation. Yeah. And sometimes you don't, and it can be very mild. So yes, we know that this is working. Yes, we do use Dr. Pierre Villa exercise. And what we believe in, you have to reeducate, to go to nasal hygiene and reeducate the nose, and of course, tongue functions. And we know that this is working. So to conclude, in our study, oral breathing, impaired nasal dilator reflex, and tongue motor immaturity were more associated with increased apnea-hypopnea indexes than the craniofacial features or malocclusions in the long term. So yeah, for an orthodontist, it was a little hard too, but this is research. This is the way it is. Thank you.
Thank you very much, Dr. Cohen-Levy. We're very excited too about some of your upcoming results.